Really excited about this session called The Heart of the Matter, Improving Adverse Effects. My name is Blaes. I'm a medical oncologist at the University of Minnesota. And the way the format is going to work today, I hope you've had time to view the posters and interact with many of our poster presenters. We have two discussants who are going to go through each of the sets of posters. And between the first set and the second set, there'll be time for questions. With that, there'll be about a 15-minute presentation kind of summarizing the posters that are here. Following that, there'll be time for discussion, and then we'll switch to our second set of presenters. All of you that are here, if you were not here yesterday, there's opportunity to ask questions at the podium. There's also opportunity to post your questions online through the app, and so feel free to take a look at that or to add to that conversation during the course of this session. So without further ado, I have the pleasure of introducing Dr. Sara Sammans, who's going to be our first discussant. Sara is a breast medical oncologist at the Dana-Farber Cancer Institute and is going to be talking about the dark side of immunotherapy success. Thanks, Dr. Sammans.
Thank you so much for everybody who woke up to be here this morning. And I also just want to implore you to go look at the posters yourself because I don't do them justice and it's just absolutely incredible work. I first want to start out by dedicating this talk to one of my patients who is a 32-year-old BRCA carrier with stage 3 triple-negative breast cancer who I gave neoadjuvant Keynote 522 to. She had a pathologic complete response and is most likely cured of her disease, but she developed permanent adrenal insufficiency and now will no longer be able to carry her second child. So there is a risk to what we do, and it's incredibly important work that the authors here have done. These are my disclosures. So first, we'll review the immunotherapeutic toxicity from pivotal clinical trials. We'll review the real-world incidence of acute and delayed immune toxicity displayed by the authors in these posters. And then we'll also review some risk factors to the development of immune-mediated toxicity. We'll also review a topic that's not discussed enough, certainly in the breast cancer world, which is the risk of cardiovascular and thrombotic events that are related to our immune checkpoint inhibitors in a breast cancer population. So we are using a lot more immunotherapy in oncology in general. I saw a statistic the other day that nearly 40% of all cancer patients are eligible for immune checkpoint inhibitors. In the breast cancer setting, we're mostly using it in the curative triple-negative neoadjuvant setting for our stage 2 and stage 3 patients, where we're using Keynote 522, which is pembrolizumab added to multi-agent chemotherapy. In the palliative metastatic setting, we're using immunotherapy in our stage 4 triple-negative PD-L1 positive patients, and a smaller fraction of patients that have TMB high or microsatellite unstable disease. But as time goes on, indications for immunotherapy are only going to get larger. Possible near-term future indications or even a high-risk hormone receptor positive population. So it is crucial that we do work to understand the side effects of these therapies. We're using the vast majority of immunotherapy in the neoadjuvant setting just because of sheer numbers of patients for our stage 2 and stage 3 triple-negative patients. And these are the 5-year results from the Keynote 522 study, which added pembrolizumab to neoadjuvant chemotherapy, showing a 9% improvement in 5-year invasive disease-free survival and a 5% improvement in overall survival. But what this tells us is that the majority of our patients are actually not benefiting from immunotherapy. You can see that we cure about 82% of them without any immunotherapy at all. And we have no way to select these patients, which is a problem. What is the cost to adding immunotherapy to all of these patients? Keynote 522 reported their side effect profiles. On the left is all-comer treatment-related adverse events that were greater than 20%. And things look pretty similar between the green bars, which are the pembrolizumab added to chemo, versus the red bars, which are placebo. But then when you take a more granular picture at these immune-mediated adverse events, you see stark differences. And in the final 5-year analysis of Keynote 522, they updated their immune-mediated toxicity incidence. 35% of patients will have some form of all-grade immune-mediated toxicity. That's 1/3 of our patients. And 13% of them will be grade 3 to 5. There were 4 treatment-related deaths in Keynote 522, and I would say 3 of them were immunotherapy-related. 1 was pneumonitis, 1 was encephalitis, and 1 was PE, which is possibly related. And so, these are things to really think about. Immune-mediated toxicity, some people call it immune-related adverse events. I'm going to call it ITOX for short, are the off-target effects of an excessively activated immune system. And we've done a good job at describing what this could be over the last decade, but it's really itis of any possible organ that you can imagine. And when you do biopsies of these organs that are involved, you'll see T-cell immune cell infiltrate on the affected biopsies. They're generally responsive to immunosuppression. And when we talk about these, we actually don't usually talk about the cardiovascular risk factors, like the myocardial infarction, venous thromboembolism. So I'm glad that we'll be able to highlight that today. Dr. LeVee and colleagues in poster 503, over to the left, did a real-world analysis of both the incidence and risk factors of developing immune-mediated toxicity in early-stage breast cancer patients. And she looked at patients with stage 1 through 3 breast cancer who used immunotherapy at 4 academic institutions between 2014 and 2024. ITOX was defined as any toxicity by an oncology provider that was thought to be possibly or definitely related to immune checkpoint inhibition or treated with high-dose steroids. And very strikingly, the incidence in this 423 patient real-world analysis of immune-mediated toxicity, any grade, was almost 73%, which is 2 times higher than reported in the Keynote 522 study. And about 19% of those events were high grade. You can see to the right the types of immune-mediated toxicities that were reported. The most common was thyroiditis, followed by rash, colitis, hepatitis, and then adrenal insufficiency. The most common grade 3 event was adrenal toxicity. And so this is really kind of astounding to see. And so I thought to myself, and Dr. LeVee and colleagues pondered, what are the possible explanations for having higher ITOX in this real-world population than was reported in registrational clinical trials? And I think there's probably a variety of reasons, but there's certainly patients in this real-world series that have medical comorbidities, as is common with a real-world population. Age, race, menopausal status was pretty similar to that reported in Keynote 522, but patients in this series were just sicker. They're a real-world population. Several of them had prior autoimmune disease, they had pre-existing lung disease, some of them even had chronic kidney disease, and so, it's a sicker real-world population. It's also very possible that there's some underreporting, under-attribution in registrational trials, which we could ponder. The other thing that is important to note is these authors really looked at toxicity even after immunotherapy administration. And in Keynote 522 and most registrational studies, we stop looking at adverse events 30 days after the patient has received drug. And so that's probably also, we have longer-term follow-up in these studies. There are some other real-world data analyses of ITOX in early-stage breast cancer that have been done. Just a couple months ago, the MD Anderson folks published their series of about 233 patients with early-stage triple-negative disease. They actually found a level of immune toxicity more on par with Keynote 522, but there are other series that show elevated incidences as well. Dr. Jacob and colleagues looked at something very interesting in a similar cohort. It was a multi-institutional 700-patient cohort of breast cancer patients of all stages. 84% of them were triple negative, 74% of them were early stage. And in this analysis, they looked at delayed toxicity incidents, post-treatment toxicity incidents, and long toxicity incidents. They defined delayed toxicity as any treatment that occurred greater than 90 days after the start of immune checkpoint inhibition. Post-treatment toxicity was anything greater than 60 days after immune checkpoint inhibition stop, and long toxicity was 1 year after ICI initiation. What they found was that the incidence of all eye toxicity in this series was about 61% at any time, and there was a 34% risk of delayed toxicity, so greater than 90 days, 3 months after starting. Something that's also very intriguing is 8.6% of patients had immune-mediated toxicity that developed after they were done with their treatment, which I think is really important for us to know and understand in the clinic. And 4.7% of patients had a toxicity 1 year after ICI initiation. You can look at the poster for the types of delayed tox, mostly thyroiditis, dermatitis, colitis, and hypophysitis. There has been a lot of research out there in different tumor types about what the risk factors for immune-mediated toxicity are, and they're really all over the map, and they're very tumor-specific. So we know that patients with lung cancer have a higher risk of pneumonitis. We know that melanoma patients have a higher risk of skin-mediated toxicity, but there has really been a paucity of data in terms of risk factors for breast cancer-related immune toxicity. And so Dr. LeVee and colleagues in the same poster noted earlier, in that series of early-stage breast cancer patients looked at the risk factors for developing high-grade immunotoxicity in early-stage breast cancer. And what they found was that age greater than 50 and chronic kidney disease were identified as possible predictive risk factors for high-grade immunotoxicity in their real-world cohort. Dr. Jacob and colleague also looked at risk factors for delayed immunotoxicity in their 700-patient real-world series. And what they found actually was interesting. They found that early-stage breast cancer patients were at higher risk of immune-mediated toxicity than the metastatic patients. They also found that baseline eosinophilic count was a risk factor for development of ITOX, and also increasing number of cycles with a cutoff around 4 cycles increased the risk, which I think is very interesting. Dr. LeVee and colleagues also looked at whether or not using bone-modifying agents increases the risk of immune-mediated toxicity. And this is the first time this has been looked at in breast cancer. And they performed a single institution retrospective study of breast cancer patients who received pembrolizumab between 2017 and 2024. They looked at 425 patients on pembrolizumab, and of those patients, 55 patients were also concurrently treated with denosumab, and 31 were treated with zoledronic acid. 67% were postmenopausal, and 40% were stage 4. What they found was interesting. The rate of severe immune-related adverse events was higher in patients who received denosumab versus those who had no bone-modifying agent at 22% versus 11%, and this was statistically significant. Interestingly, the response rate was numerically higher in the denosumab group, and there is an array of preclinical data showing that rank ligand may be a synergistic mechanism for immunotherapy that I think needs further exploration in prospective studies. This is the great first step, and I think we need more work to understand the risk here of concurrent administration to our patients and also the possible benefits. So my conclusions thus far are that ITOX is common in breast cancer patients on and after immune-mediated toxicity. The ITOX incidence in randomized controlled trials is about 35%, and in real-world data, it appears to be higher. The series vary, but somewhere from 35 to 73%, and the true real-world incidence may be higher due to our patients' comorbidities. Another important point is that immune-mediated toxicity is possible after we stop the immune checkpoint inhibitor in about 9% of patients. So this has impacted my practice, and I do consider checking immune-based labs even when patients are done therapy for a certain period of time. Age greater than 50 and chronic kidney disease may be risk factors for high-grade immune toxicity. Early-stage disease, eosinophil count, and number of cycles may increase risk of delayed toxicity, and we must keep doing more research to understand these risks so that we can have risk-benefit conversations with our patients. Moving on to cardiovascular adverse events related to immune checkpoint inhibition in breast cancer. This is really underreported in breast cancer registrational trials and all immune trials. What I learned by doing a lot of digging is that in large meta-analyses, it is very clear that administration of immune checkpoint inhibitors is related to cardiac events. So on the left, there is a 38,000 Denmark database series, and on the right, there's a meta-analysis of 48 RCTs in 30,000 patients, both showing almost a doubling of cardiac events, not only myocarditis and pericarditis, but also cardiac arrhythmias, cardiovascular death, myocardial infarction is increased. Dr. Chiang and colleagues in poster 501 looked at the incidence of cardiac events associated with pembrolizumab in breast cancer patients in a propensity score-matched cohort study in a real-world database. They took female breast cancer patients who received pembrolizumab, and they did a propensity-matched cohort of almost 1,300 patients treated with chemo-IO versus 1,300 patients treated with chemo alone. And they found 2 times the amount of major cardiac events in the patients treated with pembrolizumab. And you can see here 9.9% risk in the patients treated with pembrolizumab versus 4.5% in the chemotherapy alone. And it's not just the myocarditis and pericarditis. There was an increased risk of atrial fibrillation, congestion disorders, myocardial infarction. And so there was an extra 4.5 cardiac events per 100 patients in those treated with pembrolizumab. There is a lot of literature on why this is. Studies actually show acceleration of atherosclerotic plaques after immune checkpoint inhibitor treatment. And there have been several studies biopsying these lesions in both preclinical models and patients showing that the increased plaque formations have T-cell accumulation and activation of the blood vessels. A certain type of dendritic cell has recently been identified as a hub for this IC-mediated signaling, and in preclinical mouse models, using type 2 diabetes and lipid-lowering therapies could actually alter these immune cell interactions, and we should really think about preventative strategies for these patients. Dr. Chiang and colleagues also looked at the risk of venous thromboembolism in pembrolizumab-treated breast cancer patients in a similar propensity-matched score of breast cancer patients treated with pembro-IO versus pembro-chemo versus chemo alone. And they found that patients treated with pembrolizumab were at increased risk of venous thromboembolism as well. And at 1 year, 10 out of 100 patients on pembro had a venous thromboembolism versus 7.3 out of 100 on chemo alone, so an extra 3 VTE events out of every 100 patients. So my conclusions for the cardiovascular portion of this talk are that cardiovascular events are more common in breast cancer patients receiving immune checkpoint inhibitor, and this entity is well described in other tumor types as well. We really need to be thinking about risk reduction strategies and referral to cardiology for patients with risk factors on IO, such as hypertension, hyperlipidemia, diabetes, obesity. Venous thromboembolism is common in breast cancer patients in general. An immune checkpoint inhibitor may increase the risk, and we must be vigilant in the clinic. I really want to thank all of the authors for just fantastic work on all of these posters, and now we'll go to the panel.
Thank you. Thank you, Dr. Sammans, for that wonderful presentation and summary. If any of you have questions on any of our authors or for Dr. Sammans, feel free to come up to the podium or put questions in the chat. And I'll go ahead and get us started from some of the online questions. And this is open to sort of all of the panel discussions. One of the questions that came through is, did anybody look at whether dosing impacted the adverse events? So the Q3 week versus Q6 week, weight-based dosing versus flat dosing.
I think this in regards to the immunotherapy. You know, in our database, there were many different types of immune checkpoint inhibitors used and different dosing. And so when you broke it down, it wasn't always easy necessarily there weren't necessarily enough patients that didn't have pembro at the Q3 week dosing. So I wasn't able to really pull that out. We did looked a little bit at the partners. Again, the chemotherapy partners were varied for all the patients in this study, but we looked at whether anthracycline use was associated with increased risk, and we didn't find that it was.
Thanks.
I'll just say similarly for our study as well, we didn't look at it too using the same database, but it's an absolutely great question and should be looked at further.
Yeah, I think it's an interesting question when you go through all the literature, and I don't know, Dr. Sammans, if you came across any of that in your own review as well, but I think as we think about both during treatment, but also delayed effects, future work looking at actually is there a difference in terms of how we dose the immune checkpoint inhibitors? And Dr. Jacob, your work, you also looked at some novel agents in yours, so not all of them included pembrolizumab.
Correct. Many patients were on clinical trials, so they may have had other checkpoint inhibitors that aren't currently approved. I did want to say that in our study, we looked a lot at number of cycles, so not necessarily dosing, but we found that increased number of cycles was associated with increased toxicity. And we looked to see if there's any number of cycles in particular, at which point the risk significantly increased. And we found that for both early stage and metastatic patients, around 4 cycles is when the risk of at least delayed toxicity significantly increased. And so that, I think, is interesting to think about. Obviously, this is a retrospective database. I don't think that this is something that's ready for like any practice changes, but it does beg the question, do we need to be giving so much immune checkpoint inhibitors to achieve the same result? And, you know, there are de-escalation trials ongoing, like optimized PCR, which randomizes patients after achieving PAT-CR to either no pembro or ongoing pembro. But I think it also begs the question, do we need so much in the neoadjuvant setting? You know, the original pembro arms in I-SPY had initially 4 cycles and then 8 cycles. So I think, you know, that would be interesting question. Do we need to give so much in the neoadjuvant setting as well?
Yeah, I agree with you that I think the de-escalation, those trials, especially like optimized PCR, how important they're going to be in terms of looking at long-term effects. At the microphone, Dr. Dent.
Yeah, hi. Sorry, Susan Dent from the University of Rochester, New York. Congratulations to the authors of those great posters and for Dr. Sammans for the great summary. I think, you know, what you've pointed out is that there are cardiovascular toxicities to the treatments that we give. And I think as oncologists, we tend to be more reactive than proactive. We tend to wait, and when something happens, we reach out to our cardiology colleagues to try and fix things so that we can give them more therapy, whether that be a myocarditis induced by ICI or heart failure. And so I think it's time really for oncologists to start thinking more proactively and thinking about risk up front and co-management of comorbidities for our patients. We're treating older patients who have hypertension, diabetes, dyslipidemia. So in 2022, actually, the European Society of Cardiology published a cardio-oncology guideline, which talks about 9 of the most common classes of drugs that we offer. Anyways, talking about how we can look at risk stratification up front and actually engaging our cardiology colleagues earlier to try and manage some of these issues so that we can prevent cardiovascular toxicity rather than trying to treat it when it happens. Since we know that's not good, and also it could prevent us from giving the therapy that, you know, we want to give, life-sustaining therapy. So not really sort of a question, but just a comment that I think it behooves us to sort of start thinking earlier rather than trying to fix things when they happen.
Thanks for that comment. And for those of you who haven't looked at the European Society of Cardiology and the ICOS cardio-oncology guidelines, they're a great resource in terms of, and that actually leads me to one of the other questions that came in on the online portal. So Dr. Chiang, I wonder, one of the questions came in about, you know, should we be monitoring for cardiovascular AEs on immunotherapy? Were things in your particular study, were any kinds of baseline screening such as echocardiograms or cardiac biomarkers utilized? And do you have any thoughts about that?
First of all, thank you for the question. I think that's a great question that was not particularly addressed in our study. As far as to the best of my knowledge, I'm not aware that there's like a standardized. It also depends on the institution, but I'm not aware that that might be a standardized protocol for patients on pembro. I know, you know, breast cancer patients on anthracyclines routinely get like an echocardiogram, but that may not be the case for pembro. I could be wrong, but it depends on the institution. But I think our data supports, possibly incorporating this kind of routine screening, especially if patients are getting dual checkpoint inhibitors or checkpoint inhibitor treatment along with anthracyclines therapy or some other radiation therapy that can harm the heart. So I think, it can be incorporated as part of the screening strategy. And I think alluding to the earlier point with regards to addressing underlying risk factors, lifestyle, or underlying comorbidities that can increase the risk of cardiotoxicities in this patient will be important too.
Dr. Chiang, did you look in your series about the additive risks of anthracyclines with ICI? Was that able to be done?
That's a great question. We did not specifically look at those because it is not a big part of the population. We did have 1,000 over patients, but to my knowledge, it's only about 20% of patients who got anthracyclines. It'll be interesting to look at that as a next step, but we did not look at it as of now.
Thanks. One of the other questions, and perhaps Dr. LeVee, you could take there's two questions. One was around whether or not there was any variation in toxicity observed related to race and ethnicity. And the second was, and this is open to the panel, whether or not if you have thoughts about how long we should be following patients and how, and then does this correlate with symptoms from the patient perspective as well?
Great questions. So we did, on a univariate analysis, find that race was a factor in the onset of an immune-related adverse event, with white patients having the highest risk of an immune-related adverse event. However, this was not significant in the multivariate analysis. So a little bit unclear whether or not there's a signal there. But in terms of follow-up, I think guidelines are really just not that standardized right now for how long we need to follow the immune-related adverse events and getting a TSH or a cortisol level. So it's a great question, and I think we need to look into it.
I also just want to add, in our data set, the latest toxicity we saw was about 5 years after the start of checkpoint inhibitor. So just as a note that these toxicities can be very late. And it's especially difficult with hormonal immune toxicities, adrenal insufficiency, thyroid, just because the presentation can be a lot more insidious and more difficult to diagnose, at least initially. And so I think, especially for early stage patients, when, in the postoperative period, your number of visits may start to decrease, that it might be a good idea to really educate patients that things can still happen, to educate the team that you might need to be getting a low threshold for sending TSH and cortisol and checking glucose, as Dr. Sammans mentioned, and just to be aware that these effects can really be even years after starting the therapy.
One other question for Dr. Chiang. Is the risk of VTE expected to occur early after IO induction due to changes in the coagulation system, or do these events happen time unrelated?
That's a great question. So with regards to a general, cancer-associated thrombosis, it's kind of commonly acknowledged that the risk of cancer-associated thrombosis starts within 6 months of a cancer therapy. So I would, to that end, I would say that at least what we found was that the risk of pembrolizumab-associated VTE is actually higher within the 6 months of pembrolizumab therapy, and then it kind of gradually goes down at the 1 year mark. So I would say that it's time dependent. Patients do have an increased risk of VTE within the first 6 months of therapy, as we note in different types of cancer therapy. And as to the mechanism, I would say it's probably treatment-induced inflammation, stuff along that line. Yeah.
Well, thank you to our incredible panel. We really appreciate the discussion, and congratulations on all of your posters today.
Thank you.
I'm going to invite up our next discussant as well as our next poster presenters. Great. So our next set of posters are going to be presented by Dr. Marcela Mazo, who's an assistant professor at the University of Texas, San Antonio. She's one of the breast oncologists here as part of the Mays Cancer Center, and we're thrilled to have you here.
Well, good morning. It's a pleasure for me to be here, and I hope you all had your coffee to stay awake and warm. So this is the title of my talk. It's my absolute pleasure to have the opportunity to discuss these 4 abstracts and share my thoughts, and I'm looking forward to hear your questions. These are my disclosures. So in order to provide ideal breast cancer care, we have to take into account multiple factors. Obviously, we want to be able to deliver effective anti-cancer therapy. We still have to be mindful of the potential side effects that we're going to give these patients, both in the physical and emotional aspect. Sometimes forgotten, but just as important, we have to take into account the financial toxicity that we're going to give to these patients in the prime of their life. And obviously, we want to be able to develop strategies to safely transition them into ideal survivorship care. The 4 abstracts that I'm about to discuss touch on different points that are pertinent to what is considered to be ideal breast cancer care. So I'm going to kick off the discussion looking at Dr. Müller's work. So this is an osteonecrosis of the jaw in patients with metastatic breast cancer treated with denosumab in a phase 3 clinical trial comparing 4 versus every 12-week dosing. So as we are aware, about 2/3 of our breast cancer patients in their journey will have a skeletal-related event. What I mean by that is they can develop a fracture, they can develop core compression, they can develop need for radiation, and of course they can develop pain as a result of this. Thankfully, we have enough evidence to back up the use of biphosphonates and RAC ligands as a way to prevent the occurrence of these side effects and the subsequent effects that patients can suffer. These agents, unfortunately, come with some risk factors, and osteonecrosis of the jaw is one that is classic to them. So in this study, they enrolled patients that had metastatic breast cancer. There were also patients with prostate cancer that were enrolled, and they were randomized into a 1-to-1 fashion to either standard dosing of denosumab 120 milligrams every 4 weeks versus an experimental arm that loaded patients with denosumab 120 milligrams in the first 3 months. They received every 4-week dosing, and subsequently, they were switched to every 12-week dosing. The primary endpoint of this study was the time to first on-trial symptomatic skeletal-related event, but in this particular poster, we're going to look at one of their secondary endpoints, which is toxicity, specifically looking at osteonecrosis of the jaw. So they have an impressive number of 50 centers. When I spoke with Dr. Müller, pretty much every center in Switzerland was able to participate in this work. These patients were followed so far for 3.4 years. The clinical evaluation for osteonecrosis of the jaw was done by the treating oncologist, and if they were suspecting that the patient was having a complication, then they will have a discussion as a team to determine if it was an infection or osteonecrosis of the jaw. If you look at the number of doses that both arms got, you will see that the experimental arm had about half of the dosing that patients on the standard of care treatment arm received. So when we look at the results, and I will highlight here on the right side of your screen, you will see that on the top graph, you see patients without osteonecrosis of the jaw. The experimental arm is the arm that has less events. And when we look at the graph in the bottom, they combine the incidence of osteonecrosis of the jaw with tooth infections. And when they combine these 2 outcomes, the delta was 6.2%, favoring less osteonecrosis of the jaw and less tooth infections with the patients that we treated with the experimental arm. Obviously, we are eagerly waiting to find out data on the skeletal-related events, and Dr. Müller, before we start our discussion, shared with me that hopefully for SABCS in 2 years, we'll have some results to see if this is something that we could consider using in our practice and that could potentially change the way that we give denosumab to our patients. So what do we know? What is the seen toxicity or the seen effects that we see with these medications? So in this LeVee study that was presented some years back, they compared the use of zoledronic acid in a monthly basis with also every 3-month dosing with denosumab. It is no surprise, and most of us are aware of this, that denosumab is superior at delaying the appearance of these skeletal-related events. However, a significant toxicity is the fact that this medication has a significantly higher cost when we compare, for example, with zoledronic acid. Now, do we know if these patients live longer? I mean, does it make a difference when we look at survival? And this is a meta-analysis that was published in 2021. Over 7,000 patients were enrolled. They had patients with solid tumors and also multiple myeloma. And when we look at the results of this meta-analysis, it was confirmed yet that denosumab was more successful at delaying those skeletal-related events, but these patients actually, there was no difference in survival that was seen. I will highlight, though, that in this meta-analysis, patients that were treated with denosumab have higher incidence of osteonecrosis of the jaw. I wish this clicker will work. There you go, now it's working. Now, when we look at osteonecrosis of the jaw as a complication, when we look at LeVee, if you see the results on your screen, there was a numerical difference in the incidence of osteonecrosis of the jaw. However, this difference was not statistically significant. I will also like to highlight this publication of Nordic countries in which they follow patients for 5 years, and you can see that patients treated with denosumab had higher incidence of osteonecrosis of the jaw, and the same was true for patients that were started on treatment with zoledronic acid and subsequently were transitioned into denosumab. So this Q3-month dosing seems very attractive. Potentially giving patients less doses could mitigate the cost of these medications, but obviously until we have the data that looks into the reason for why we give this medication to our patients, which is the skeletal-related events, we are not yet ready to change our practice just yet. Now, involving into our second abstract, this was the work of Dr. Maris and colleagues. This was the young woman breast cancer study. This is a multi-center prospective study that enrolled women that were aged 18 to 39 years old that were diagnosed with early stage breast cancer, stage 1 and stage 3. Two-stage 3, and patients were surveyed for financial difficulty using the cancer rehabilitation evaluation system. And they interestingly also look at arm morbidity, symptoms that the patient had when they were having difficulty with their arm. I will clarify that this study was not powered to look for lymphedema, but it is mentioned in the results that I'm gonna touch on that specifically in a moment. So what were the seen characteristics of these young women? So 42% have stage 2 disease. It is no surprise that the vast majority of them have estrogen receptor positive disease. When we look at the treatments that they receive, 70% of them had a mastectomy, 62% received radiation, and 75% of these women received chemotherapy, perhaps alluding to more aggressive forms of breast cancer. It is no surprise to us, and we all see this in clinical practice. We know that the incidence of breast cancer in the young women is on the rise. There was a publication by Cancer Facts and Figures from last year that reported that the incidence of cancer in women younger than 50 years old is on the rise. Now, when we look at the results, they model some longitudinal trajectories to be able to predict financial difficulty paired with some clinical features. They were able to come up with 3 trajectories, as you see on your screen. So trajectory number 1 was 54% of the patients. These are the ones that had low financial difficulty. Trajectory number 2 were 30% of the patients, and they had mild difficulty that with time got better. And then the trajectory number 3 was 17% of the patients that had moderate to severe difficulty, that peaking several years after diagnosis before it actually improved. So this portion of patients took a long time to recover. Now, I wanted to highlight this work of Dr. Parsons. This was published in 2023, and it really shows you what is the cost as a society that we pay and that our patients pay when they are diagnosed with cancer at a young age. This report specifically doesn't look at breast cancer. This looks at cancer in general for the young population. And you can see on the table of your left the average calculated cost for our patients when they're diagnosed with breast cancer at an early age. Definitely, we need more strategies to help these patients with financial toxicity, and we perhaps need better strategies to also screen the young, because we all know that cancer is not anymore a disease of the old, and it's being very common in the young as well. When we look at the results, so they were able to link certain clinical characteristics with the low trajectories, meaning the ones that had more financial difficulty. So the ones that I would like to highlight is a BMI higher than 25, so patients that were overweight and obese, patients that had bilateral mastectomy, patients that were members of a minority, so the Hispanic ethnicity. Although this was only 5% of their cohort, it's a health disparity, of course. Unemployment at baseline in a year after they completed the treatments, and patients that express more arm symptoms. Again, perhaps hinting at some complications such as lymphedema. Again, the study wasn't powered for that, but that kind of caught my eye. So these clinical characteristics were predictive of trajectory 2 and 3, which are the patients that struggle the most. What are my conclusions? Maybe we need to have better therapies to de-escalate our patients. Maybe, we have better strategies to decrease the need of doing mastectomies, because a high proportion of these patients had mastectomies. Minorities, there's no secret for any of us that they're more vulnerable, and this is a health disparity. Lymphedema as a seen complication is one that I feel is deeply understudied, and there's some data that suggests that minorities have higher incidence of lymphedema, both in the Hispanic and the African American population. And we really need better interventions to mitigate financial toxicity for this patient population. Looking at Dr. Lendorf's work, so this was a study, a randomized multi-center study, looking at the effects of cryotherapy in patients that were going for curative chemotherapy, receiving a taxane, either docetaxel and paclitaxel. So these were histologically confirmed cases of early-stage breast cancer that were going to receive either paclitaxel or docetaxel. Patients were randomized into a 1-to-1 fashion to either usual care, basically you do your chemotherapy as you normally do, versus offering elastogel frozen gloves and socks in the hands and feet. This is cryotherapy that was given 15 minutes before, during the infusion of the chemotherapy, and 15 minutes after the patients were done with the infusion. And their endpoints was the incidence of chemotherapy-induced peripheral neuropathy, and they also look as a secondary endpoint to quality of life, more than grade 2 neuropathy, sensory and motor neuropathy, as well as the quantitative sensory tests, looking at temperature and perception and tactile sensitivity in these patients. When I went back and looked, and this got me thinking, what do I do in my clinical practice to mitigate the risk of neuropathy for my patients besides dose adjusting and doing a good physical exam and talking to my patients? And when we look at the ASCO guidelines, these agents that you see in front of you are agents that have been looked at, that have been tested to see if any of them work to prevent neuropathy. And the truth of the matter is that none of them shows any strong evidence that they're helpful. There is some emerging data with the use of duloxetine to prevent neuropathy, and this is in the early stage. We probably need bigger studies to be able to confirm that benefit. But the truth of the matter is that when we look at pharmacological interventions in our own guidelines, we don't have a lot of agents to use. When we look at non-pharmacological interventions, we have some that were mentioned. Obviously, exercise is one. It's good for our patients for many reasons. There's also some studies that look at acupuncture. Patients overall felt better. It was mentioned also sclamber therapy with electrocutaneous, kind of little currents as a treatment to prevent neuropathy. Again, the data on that was not very convincing. And cryotherapy and compression emerged as an alternative, and the authors look at this too. But again, as I said, we don't have any agents that we recommend to prevent chemotherapy-induced peripheral neuropathy. So when we look at the results, if you see the different diagrams, you will notice that although there is some numerical differences that favor chemotherapy, Overall, the difference was not statistically significant, with the exception of the tactile disturbance by the monofilament test as expressed by the patient. So this is the graph that you see that has a p-value of 0.006, and that difference was statistically significant. The authors also look at changes in dosing, dose reductions, or premature cessation of chemotherapy, but there was no difference when we compared both groups. So although there was not a significant or big difference, I think it's an important benefit for our patients to report less sensory symptoms and feel better. I will acknowledge that monofilament test is a test that is very subjective, and we probably need better tests to be able to check tactile sensitivity. But to me, this intervention is one that is cost-effective, that most patients are able to afford, and that definitely could help patients feel better. In this area specifically, I feel as a medical community, we need better biomarkers to be able to find out which patients are at higher risk of suffering chemotherapy-induced neuropathy, so we can proactively modify their dosing as we treat them. And the last abstract by Dr. Stan, so I thought this was pretty genius, and it's an interactive care plan that is given to our patients in an app base. Basically, after they completed their treatment, they were offered the opportunity to participate and have this app available to them to be able to log some symptoms and get some education materials. They enroll patients in between 2020 and 2022. So as we all know, a tricky time in our history when the COVID-19 pandemic was happening. Patients were overall young. The median age was 56 years old. And when we look at the type of reminders that they were getting, so they were getting daily reminders to be active and to exercise, monthly assessments of toxicity, such looking into fatigue, insomnia, sexual dysfunction, and hot flashes. They also had monthly questionnaires looking at symptoms that could represent disease recurrence. And when there was a concerning symptom, this was then passed along into the clinic staff to be able to address this concern and determine if that patient needed further testing for the possibility of having a recurrence. They also look at the quality of life questionnaires, and they also offer patients on-demand education materials if they were interested in a specific topic. In the bottom of the slide, you see the number of messages that the clinic staff got in a 1-year period, and you will see that most of the messages were related to symptoms that were worrisome for recurrence. There were some symptoms also related to anxiety and depression. And I'm happy to report that even though 251 patients messages seems like a lot, when we look at the number of patients that would enroll, it was, I guess, something that the clinical staff was able to handle, and it wasn't significantly heavy on them. When we look at the percentage of participants endorsing symptoms, so you can see that in the initial survey, so this is the baseline and the 3-month mark, patients reported more vasomotor symptoms, but you can see that as they recover, the incidence of those symptoms was progressively decreasing. Same for sexual dysfunctions, same for insomnia and fatigue. However, I guess as our patients felt better, the engagement started kind of decreasing over time. And you can see here that at the beginning, a lot of patients were reporting a lot of, for example, sexual dysfunction. But when we got to a year, a lot of those patients were not being as engaged as we wanted them to be. What they were looking for is to see if this was something feasible. And again, this was offered to patients in a very difficult historical time. And the answer is that yes, it is feasible to give patients an app-based on their phone that they can look at and get reminders to be healthy and to stay active. Although the engagement of the patients decreased over time, overall they were able to gain insightful information. When we look at the potential of technology as a way to monitor our patients and educate, I think there's a lot of potential that we have in this area. If we could potentially engage more patients that are living away from clinic, that maybe are going back to work and have difficulty coming back to clinic. So overall, I think these technologies offer a lot and that we probably have not seen. And as my final conclusions, I would like to highlight that financial toxicity is a very frequent yet overlooked problem that we have. We give a lot of successful treatment to our patients, but we gotta be mindful that we're giving them a lot of financial toxicity on top of physical toxicity. I feel like self-management tools are very important, and they have a lot of potential that we haven't probably exploited. And as my last conclusion, I want to say that appropriate de-escalation when it comes to finding the right dosing, for example, in abstract number 1 that I discussed, is very important. And certain interventions, such as the cryotherapy work that I presented, could potentially help our patients to reach that goal of having a successful outcome. And with that, I'll stop, and I'll thank you. Thank you for your attention.
Thank you for that great presentation, Dr. Mazo. I know you covered a lot of material over a large number of different adverse effects. If any of you have comments or questions, put them in the chat. I'll go ahead and get us started. So, Dr. Müller, I am struck by high rates of ONJ, and this doesn't go away for our patients. And I think in your particular research, it looked like most of the patients were on treatment for about 2 years. Many of our patients are living longer and longer, and I'm curious if you have thoughts yourself about how we should be thinking about this in terms of the optimal usage of bone-modifying agents for our patients with bone metastases.
This is an important question, since we know that the incidence of ONJ increases with duration of treatment. Our REDUCE trial is a first step in reducing the risk of getting ONJ. A next step would be to look if it is possible to omit entirely the anti-resorptive treatment after some time. But we have to look at this prospectively in the same manner as we did in the REDUCE trial.
And tell me, it sounds like you think we're going to get outcome data 1 year, 2 year. When are we really going to get the overall looking at skeletal-related events?
At the earliest in 1 year, I expect it to be in 2 years that we will have the primary analysis of the skeletal-related events.
Thanks. I think this is a big question we're all interested in knowing the results of those studies for sure. Doctor, go ahead, the microphone.
Thank you. Roger from Switzerland. I'm the coordinating investigator of the whole trial, which includes not only breast cancer, but also prostate cancer patients. Maybe just one misunderstanding. Our primary endpoint is not skeletal-related event. It is symptomatic skeletal-related event, which means we are not catching up fractures who are asymptomatic and doesn't play a role for the patient at all.
Thank you. I think that's an important point to point out, so I appreciate that. The other microphone?
Good morning, Dr. Maroon from Dubai. So my question is regarding taxanes and chemotherapy-induced peripheral neuropathy. Did the small difference of monofilament translate into any clinical benefit for these patients? The difference by using cryotherapy, did it affect their clinical symptoms or?
I'm sorry, I couldn't hear you.
Yes.
I don't know. I think the question is for Dr. Lendorf, if you had a...
Yes. Thank you. Thank you for that question. Well, we see that the objective sign, we saw a reduction in neuropathy with the monofilament testing. We saw a positive effect of the cryotherapy, but we also saw the positive effect of the cryotherapy in the patient-reported outcomes. So it kind of makes sense that the objective sign consists with subjective symptoms. The question is if it's a clinical relevant benefit, and I think the short answer would be it's too early to say. We saw a difference right now. We didn't see any difference in quality of life from the patient-reported outcomes, but this evaluation was drawn end of treatment, meaning 3 weeks after the last taxane treatment. We will do follow-up for the next 3 years with these patients, evaluating them every 6 months. And here, this month, actually, we will receive 1 year evaluation And now it will be interesting to see if we still see the benefit of cryotherapy here 1 year after they finish taxane therapy. If we do that, I think it will be a definite clinical meaningful benefit.
Thank you.
Thank you for that. I have a question for Dr. Stan, and there's a question online as well about the use of the app. There are kind of two questions. One is how you reported out that the app was feasible and patients were engaged in it, and it sounds like self-management. You were able to, one, identify need and then provide education. The question online is thinking about how do you continue to engage participants. I think my question also is, do you know how this compares to kind of the usual care now, where we're assessing, for example, anxiety and depression? Did we actually do a better job using the app compared to standard?
Yeah, thank you for those very important questions. To answer the feasibility question, we defined feasibility as patient engaging with at least one task at any point in time. So we had a very low threshold, although we ideally would have liked to see have seen about a 75% engagement. And unfortunately, for the daily be active task, only about 50% engaged to begin with in the first month, and that decreased significantly to 6% at the end. And I heard from patients that was a very bothersome reminder for them, not because they didn't like that, but because it was difficult to go into the app, because this app being delivered through the electronic health system goes into the patient portal. There are many steps to get into that portal to check the mark that I did the exercise. So lots of people didn't want to do that. Would have been much easier to just have it on your phone like the normal commercial apps that you can just make a check mark. So we are trying to see how to go around that issue. I understand that I cannot go through it clinically because of the HIPAA regulations, but maybe with a third-party commercial app, we can embed that into the medical record and go around that. So feasibility, we are trying to improve. We had a patient group discussion on how would they like to implement this in the future. We already changed the app towards being a bit more patient-friendly, but still, right now we are still continuing the app, not in a research study, but I still hear from patients that it is not very friendly. What was the other issue that?
How does the collecting actually symptoms compare to general use or what's done in the clinic?
That's actually something we are planning to do in the future, to compare with a similar size group to see quality of life-wise, symptom-wise, if they did better or not. I do not have that data at this point in time.
Thanks. And Dr. Myers, so as we talk about apps, naturally I keep thinking a little bit about how can we assess for financial toxicity as some of these as well. Your great research identified certainly patients at risk for financial toxicity, and I'm wondering if you can discuss a little bit as your team has thought about how do we best assess this in the real world, because I think your study really looked at survivors.
Yeah, thank you for the question. I think there are a couple of issues. Certainly you can use an electronic platform to disseminate surveys over time longitudinally, but the surveys need to be pretty specific to the patient population. The adolescent and young adult cohort in particular struggles because some of the questions about financial toxicity aren't necessarily salient for them. So the cost metric, the comprehensive scale for financial toxicity, which is one of the most well-validated metrics, was validated in patients with advanced cancer who were older. We still need a better validated metric for this population. You can do it serially over time, but there are issues to contend with, like survey fatigue and organizational preparedness in order to disseminate that. And the other problem is that these patients need to be followed for a long period of time because the difficulties that they're seeing in terms of their finances may not be readily apparent in the active period of treatment, especially if they're contending with treatment-related adverse events that don't manifest until 2 or 3 years after their initial treatment. And so even if they're enrolled in some sort of platform to assess symptoms early on in their treatment, they may be disengaged by the time they're experiencing the financial difficulties. So yes, that is one avenue, but until we understand how to engage the patients longitudinally, I think the electronic platforms may be difficult.
Thank you for that. One of the other questions that came in online, and I'll open this up to the panel, they asked about sort of the need to discuss physical activity. Now I think about that with wellness on the financial side, but also on the neuropathy and skeletal health piece. I'm wondering if anybody on the panel has thoughts, or Dr. Mazo, yourself too, about sort of the importance for all of us as oncologists to talk about physical activity. I think that was one thing looked at in the app.
From my perspective, I think that has to be discussed with everybody. We actually have a one time, we call it a survivorship consult, when the patient comes in and is being seen by one of the nurse practitioners in the oncology clinic, and she's part of the integrative care, and this is being discussed at that visit with every patient, and then reinforced every 6 months on the surveillance visits. And we put that as a first step, and I usually tell the patient the next step would be to look into your diet, make sure you eat a healthy diet, and then the weight maybe comes next, but the exercise definitely, because of the evidence in the literature that improves survival and improves all these outcomes, the neuropathy, health of the bones, and many other symptoms as well. So very important.
And I will add that with the data that we have as obesity being classified as a risk factor for recurrence, and we know that exercise has benefits for cardiovascular health, it's definitely an intervention that we should recommend to our patients that are in active treatment and survivors too, because overall it's going to translate into benefit in many aspects of their care.
Well, thank you very much to our panelists. I think we all appreciate your discussion. The authors are around for anybody who has additional questions. And with that, we'll go ahead and close the session. Thank you again.